Hi, my name is Dr. Jennifer Goldman, and I'm from Shirley Ryan Ability Lab, formerly known as the Rehabilitation Institute of Chicago and Northwestern University Feinberg School of Medicine. In my presentation, I will be talking about, has the treatment paradigm changed for Parkinson's disease psychosis? We recognize psychosis as one of many neuropsychiatric features in Parkinson's disease and among the motor and non-motor symptoms. We typically see psychosis as occurring in moderate to advanced stage Parkinson's disease, but as you will see, that paradigm may be shifting. We also need to appreciate how psychosis in Parkinson's is interrelated with a number of other motor and non-motor symptoms, such as cognition, sleep, visual function, and others. We recognize that psychosis has great importance and impact for people living with Parkinson's and their families. It can impact morbidity, mortality, and nursing home placement by increasing these. It can increase caregiver burden and reduce quality of life. We know that it can be challenging to treat and often requires balancing the motor benefits and one's mental function. Treating psychosis requires an interdisciplinary team approach, working with neurologists, movement disorder neurologists, psychologists, psychiatrists, social workers, and many others on the team. A number of years ago, a working group from the National Institutes of Health put together diagnostic criteria for psychosis and Parkinson's disease, as you can see here. Psychosis, by definition, requires the presence of at least one of the following: illusions, false sense of presence, hallucinations, or delusions. In the context of the primary diagnosis of Parkinson's and after the onset of Parkinson's, and a duration of at least a month to differentiate it from acute delirium, and to exclude other psychiatric features or delirium due to medical issues. We recognize psychosis as a spectrum. Here you can see, as depicted, minor illusions or misperceptions, passage hallucinations, a sense of presence or shadow, as well as changes that can be related in visual function. We generally recognize visual hallucinations as the most common modality in which they are seen. Hallucinations can occur with insight or without insight. They can be formed, they can be objects, moving, animals, children, and sometimes can be benign or other times can be disturbing. Delusions, which occur in about 5 to 25% of people with Parkinson's having psychosis, is often more common in the setting of cognitive impairment or dementia. Delusions often, when they're present, include those related to paranoia or fidelity. While visual hallucinations are the most common sensory modality that are seen in Parkinson's disease, and in contrast to schizophrenia, where auditory hallucinations are more common, it's important to recognize and remember that hallucinations can occur in other modalities, such as auditory, olfactory, gustatory, tactile, and so forth. This can occur for both illusions and hallucinations. Over the years, we've also recognized that hallucinations and psychosis can occur potentially earlier in Parkinson's than we previously recognized. Here are two studies demonstrating that. From the Parkinson's Progressive Marker Initiative Study, or PPMI, baseline data was collected in over 400 people with Parkinson's at their de novo or untreated state. In this population, psychosis was identified in 3%. In another study at a movement disorder center, looking at prospective collection of data from 50 people with Parkinson's, 21 or 42% had minor hallucinations and were in early or de novo stages. In both studies, psychosis was assessed by the MDS-UPDRS rating scale question querying hallucinations. In the second study, the authors found that hallucinations could occur as even a premotor symptom in about a third and was highly associated with REM sleep behavior disorder. This raises our awareness to ask and to be vigilant about early psychosis symptoms, as well as to examine vision, sleep, and cognition, which can play a role or be related to psychosis. These early hallucinations in patients followed over time, such as in PPMI, may herald cognitive decline and may also herald changes that can be depicted on neuroimaging, such as gray matter volume loss or changes in visual perceptive regions. There may be barriers to identification and assessment for which further education and awareness and teaching would be relevant. There may be reluctance by the person with Parkinson's and her care partner to volunteer these types of symptoms. Often they may be associated with stigma or considered potentially bizarre in nature. There may also be reluctance by the healthcare professional to ask due to a variety of factors, including limited time, lack of knowledge, or being uncomfortable talking about these topics. There may also be a lack of understanding about psychosis itself. How does this relate to medicines and other causes? And how do we understand what medication side effects may be present? There have typically been few screening tools available and often a lack of consensus for assessments of psychosis and Parkinson's. A number of issues can arise in the setting of psychosis from the patient side and then also from the care partner side as depicted on this slide. This may provoke anxiety or worry or fears, social isolation, a risk of injury, and perhaps leading to improper medical care. On the care partner side, and we try to avoid these if possible, they may be unaware of symptoms until they hit crisis mode, and that may lead to improper medical and psychosocial attention. Care partners also may have worry about changes in relationships, not knowing how to respond to when someone's having hallucinations or what resources are available, and this can lead to caregiver strain or financial burden. Spectrum of psychosis and Parkinson's can be really quite complex and an area of lots of study. As you can see here in the figure, we can see some of these illusions, hallucinations, and even delusions related to different areas of the brainstem, as marked in purple, as well as the limbic area and other cortical regions, as marked in yellow. These regions also can follow the outline of progressive topography, as we often associate in Braak's pathological staging. Here we can see, based on the neuroanatomy, that there may be relationships with other behavioral features relating to attention, arousal, cognition, sleep, and vision. A number of neuroimaging studies and electrophysiological studies also demonstrate changes or correlates in these areas, such as changes in structure or gray matter atrophy, changes in the connection among brain regions, perhaps gene expression changes, and other electrophysiologic markers. When we think about management of psychosis, it's important to differentiate when it is acute or of new onset versus a more chronic treatment. A number of years ago, we put together this handy mnemonic for the evaluation of acute psychosis and Parkinson's disease. Here you can see listed a number of topics that might be addressed in the clinic visit and investigations, looking at Parkinson's medicines, the presence of an illness like a urinary tract infection or pneumonia, other medicines that can affect the central nervous system, such as those for pain or bladder dysfunction, and other reasons listed here. Management also can include not only treating the underlying medical illness if present, but also stopping medicines or reducing medicines that can exacerbate hallucinations, whether they are related to Parkinson's treatments or not. We may need to reduce and discontinue Parkinson's medicines, thus illustrating that balance between the mental and motor function. Here is a proposed order from an older publication that one might consider in reducing doses or discontinuing specifically Parkinson's medicines, such as those anticholinergics, amantadine, MAOB inhibitors, dopamine agonists, COMT inhibitors, and then levodopa. There may be a role for non-pharmacologic and coping strategies such as nightlights, reassurance, or even artistic depictions of hallucinations. And then we can talk about medications for the treatment of psychosis. This is also a good point to remind people that we want to avoid dopamine blocking medications, as those can worsen and aggravate motor Parkinsonism. Over the years, the Movement Disorder Society Task Force for Evidence-Based Medicine has put forth reviews based on recent clinical trials. Here you can see several medications or interventions used to treat psychosis and Parkinson's, enumerated by their efficacy, their safety, and practice implications. Of these, we'll talk about 3 of them, but here you can see that olanzapine, by blocking dopaminergic systems, is not efficacious and can lead to motor worsening of symptoms. Clozapine has been well studied in Parkinson's psychosis with a number of double-blind placebo-controlled trials over the years. It has decreased D2 receptor affinity, regional selectivity in the mesolimbic system, and greater serotonergic antagonism, thus leading to a more favorable profile from the motor standpoint of Parkinsonism. Typically, low doses are used, as seen here, and of course, clozapine requires CBC monitoring due to its idiosyncratic side effect of agranulocytosis. Quetiapine has generally had some positive impressions, but inconsistent results in double-blind trials, thus leading to conflicting study results. Its mechanism is similar in action to clozapine, with a greater serotonergic profile. Again, low doses in Parkinson's patients for treatment of psychosis are typically used. And common side effects can include somnolence or sedation and hypotension, of course, being mindful of these in a population such as Parkinson's patients who can already have some of these symptoms. Pimavanserin has a different mechanism of action as a serotonin 5-HT2A inverse agonist and antagonist. In a clinical trial, there was demonstration of improved PD psychosis symptoms without motor worsening, as studied in a 6-week trial that led to its approval by the FDA for PD psychosis in 2016. Side effects that have been noted have been included an increased QTC, and cardiac monitoring is advisable. In a sub-study or secondary analysis of the trial, which included people with Parkinson's and psychosis with Mini-Mental scores greater than 21, it was found that those who had Mini-Mental scores from 21 to 24 were found to have a larger change in their psychosis rating scale scores than those who did not. Cholinesterase inhibitors, typically thought of for the treatment of PD dementia, may play a role in the treatment of psychosis as well. There have been several open-label and randomized clinical trials for Parkinson's dementia, from which some secondary analysis or subgroup analyses have shown benefit in those subgroups with dementia and hallucinations. There have been few double-blind placebo-controlled large studies in PD psychosis itself with these agents. One is listed here, looking at the prevention of psychosis in donepezil versus placebo, did not prevent psychosis. And it's thought that conceptually, with the relationship of cognition and psychosis, with hallucinations being more common in the context of PD dementia, that these medications may play a role. There are risks and benefits of psychosis and untreated psychosis. Risks to the patient for self-injury, risks to the family for harm. And it's important to note that there's a black box warning for elderly related to the use of antipsychotics, with dementia-related psychosis having a higher risk of death compared to those patients on placebo. One recent study looked at veterans in the United States, the VA study looking at the prescription or starting of Quetiapine, and they looked at negative outcomes as defined by death, emergency room visits, and hospitalization. In about 40%, there occurred negative outcomes over a 180-day follow-up. Clinical correlates of these negative outcomes included worsened Parkinson's disease, presence of autonomic dysfunction, and other comorbidities. In summary, there are shifts and advances in our paradigm for managing and treating Parkinson's psychosis. We have greater recognition of its clinical spectrum. We recognize some of the negative outcomes that can occur with psychosis and Parkinson's. Education and increasing awareness remain very important. We've grown in our understanding for the multiple reasons for the development of Parkinson's psychosis and interrelations with other non-motor features and systems. We can continue to grow and shift our paradigm in terms of management with a variety of interventions, individualized treatments, and hopefully the growth of new drugs under study. Thank you.